Dr. Elwing, Dr. Shaw, thanks for having us here. Fascinating conversation. We've been talking about the diagnosis and treatment of portal pulmonary hypertension and liver transplantation. And in our talks, the one thing that I know is crystal clear is that there's never a dull moment with you two. You have so much to manage. How do you summarize this battle you're fighting constantly?
Well, I think most importantly, people have to be aware that it can happen. Whether you're being evaluated for liver transplant if you have cirrhosis or you're not, that you can develop portal pulmonary hypertension if you have portal hypertension. So it has to be on our radar. And we know that patients with cirrhosis have risk anywhere from about 0.25% to 2% in terms of the development of portal pulmonary hypertension. Once you get sick enough to need a liver transplant, that goes up significantly. Your risk of having portal pulmonary hypertension is real and has to be very respected, not only to stay well before transplant, after transplant, but in the operating room. So why does it happen? We have all of these systemic shunts that are occurring because of our portal hypertension, and these vasoactive mediators are hitting our lungs and affecting our pulmonary vasculature. And because of that, our PVR is increasing, then pulmonary pressures are increasing, and our right heart is affected. And we're trying to lower that resistance in the circuit to allow our right heart to tolerate all we're going to ask it to do in the intraoperative and postoperative phase of this condition. So in terms of how these patients behave in terms of pulmonary hypertension, they're very similar to our other PAH patients. However, the complicating factor is that we don't have a lot of studies that guide us how to manage them. So we have a little bit of data on our endothelin receptor antagonists. We at UC were just involved in a study that completed. It's not yet published, but very encouraging that with macitentan, a drug that targets the endothelin receptor, we can improve patients' pulmonary vascular resistance. So just showing us that our drugs in studies can have the effect we're seeing clinically. So what do we need to know going forward? We need to know that we have a great deal of work to do. We have a lot of studies, a lot of information about outcomes that we need to look at more closely. So from the surgical standpoint, how would you summarize?
Well, we know that portal pulmonary hypertension and liver transplantation have interactive effects, and it's a big problem. And even after liver transplantation, portal pulmonary hypertension can persist for a long time and sometimes even worsen. So it requires the commitment not only pre-transplant, intraoperatively, but essentially for a long time post-transplant. And in the large proportion of patients that might not actually recover where they're still requiring oxygen, they will need to see an expert pulmonologist for a long, long time, and we tell them that. All patients that have a mean pulmonary artery pressure greater than 35 should be treated before you get to the operating room for your liver transplant. And we need to work on reducing that mean pressure in advance of the surgery. In the operating room, managing those hemodynamics is absolutely critical, and that requires the help of the work done pre-op by Dr. Elwing, anesthesiologist, and the surgeon, all working together. And that really is where the triumvirate of the team has to come into play, because the anesthesiologist as well has to be comfortable managing PA pressures going up and down in the operating room and understanding what's happening. And it's been proposed that a mean pressure less than 35 with a PVR less than 3 to 4 in the pre-transplant setting may improve results of liver transplantation and long-term survival, and that's what we aim for.
So we've talked about the difficult, gut-wrenching decision-making process that you both have to go through to help these patients. In tapping into your expertise one last time, how do you communicate this with patients and loved ones? And based on all the experience you have, what advice do you have to other practitioners who find themselves in this role?
Well, when patients come for a liver transplant, they know that it's life or death. When an issue like this has come up, especially if it's a new diagnosis, it adds a whole nother layer. And it's complicated. We're spending this whole webinar talking about this, and many doctors probably don't understand it. So I stress to them that we have a world's expert at our place that is going to manage it for them, and hopefully we can get to the operating room. If it can be controlled, if it can be managed. But we have the state-of-the-art expertise as well as the state-of-the-art medications here at our center that if there's any chance that they're going to get to the operating room, I like their odds here. After that, it's a nervous time for us. Pre-operatively, we got to get them there. Then intraoperatively, we're nervous. But even post-op, we're nervous because are the lungs going to tolerate what we did? Is the heart going to tolerate what we did? Are the medications really going to work? Are they going to get better? And sometimes when they don't get better, they do get frustrated because they were expecting to get off the oxygen. And I have to remind them that at least they have their portal hypertension resolved. Hopefully with time, the lung hypertension will get better as well.
Dr. Elling, final thoughts?
So, in my experience, I think we help them as much as we can through this very trying time, and we let them know we'll never ask them to do anything I don't think they can do. I think that's when it gets overwhelming. They're already stressed. They're already having trouble with memory because of their encephalopathy, and then I'm asking them to do very challenging things with medications. We support them with our specialty pharmacies, we support them with our nursing staff and all the people that we work with at UC, and encourage them to know that we'll push as hard as they need to be pushed to try to get to goals, and we will support them if they change their mind, and we'll never ask them to do something I really don't think they can do, because it is hard. And if I think they're struggling, or if they're going to hurt their own selves by making mistakes or having trouble with their medications, I will guide them in a different direction.
Dr. Elling, Dr. Shah, thank you very much. Appreciate your time and sharing your expertise as well.
Thank you very much.